that spinous process, you're actually over the vertebral body of the one below. And then 7, 8, and 9, if you're on that spinous process, you're actually at the disc below the next vertebra. So, one, 2, and 3. If I'm pushing here, then straight back is the disc. So it angles down enough that I'm now over the disc between the vertebrae. 1, 2, and 3. 4, 5, and 6, it's far enough down that if I push here, I'm actually over the vertebral body of the level below it. You have this face of non-comprehension.
Yeah.
That's okay. So it's not really okay, we should probably resolve that.
Can I have something?
Alright. Ready this? Steady cervical. Yes. Go straight back, right behind it. Now if I push on the spinous process of each of these, I'm directly over the disc below that vertebral body. That's 1. So 4, 5, and 6. If I push on the spinous process, I'm actually over the vertebral body of the level below. Scroll up. And on these guys, if I push on their spinous process, I'm actually getting over the discs. But there's enough downward angulation in each of those which is unique. If you look at the regions above and below, so my lumbar is pretty much pointing straight back. And they're short sloping. Whereas these guys are going down. So looking at the picture on the quiz, if you see a downward angled spinous process, it's a thoracic vertebra. The next piece is the orientation of the facet joints. So if I come back up here and I grab this and I hide the others, see, look, doesn't that look like a giraffe head? Right there. It's a giraffe's head. Cool. So if you see the giraffe head, it's a thoracic vertebra. Problem solved. The orientation of the spinous, the superior and inferior articular facets, they're vertically oriented. When you get the cervical vertebra, they lean back to about 45 degrees. And when you get in lumbar, they actually rotate inwards about 30 or 40 degrees. So the only ones that are directly vertical are thoracic. And then the last piece that you can really kind of key in on is the size of the vertebral body. So it's big, but there's definitely a difference between cervical with a little vertebral body, thoracic, and then lumbar gets huge. So somebody was saying that the lumbars look like mooses. I got a moose in it. I don't know. They're saying there's his antlers in here. It's bullwinkle. Anything else that's bugging you? No, just the picture. Okay. Glasses are first. You got some other things. So last time we found sternocleidomastoid, right? SCM, where's it go? Can you palpate it? How do you find it? So behind your ears is the best way it's going to start. And it's going to come diagonal down into the sternum and the clavicle. So it's going to go this path. So if you kind of turn your head and then tuck your chin in, it's going to make it pop. Now, interesting fact about this one, though, is if you have a clavicle fracture, where's your clavicle? Right, collarbone? So because this is attached to your collarbone, if I fracture a collarbone, it gets hit, then they typically lean their head towards and turn away from the side of the fracture. Because what that does, SCM pulls down and in. And so if I turn my head towards, it can leave tension on it. So the shortened position puts the most slack in that muscle, and since that muscle is grabbing on that bone, it wants the pressure off. So fractured collarbone, they typically have their head tilted that way, but they turn away from it as they're cradling because it takes the pressure off of that muscle, that bone.
Fractured his collarbone. So he had like a son for like 3 months. He couldn't sleep.
Who is this?
My dad.
Poor guy.
He fell.
It's tragic. All right. Sternocleidomastoid 2, edge of SCM. And carotid artery. Fun stuff. So when we take a pulse, we tend to find the esophagus right through here, and then we come to the side of it. It's kind of in that triangular pyramid to where if you find the SCM and then you find the esophagus, it's in that soft, squishy gap in between the two. Easy enough. If you really want to see a crazy video, there's a hockey incident where the guy took his skate to the throat and they hit the carotid, and like it's all on camera. I mean, yeah, he survived. He lived. He lived because they had EMS on them and fast, because that's a lot of blood loss. So first rib, which is something we should be able to find. So you go clavicle right through here, and then again you can find SCM kind of tucking over the top diagonal. And if you fall back, so if you find where SCM comes into the clavicle, yes. Oh, I didn't know. So, do you want it? It's just pictures. I'll get it to you. Can you survive until then? Yeah. Okay. I'm a hoarder. You can't have it. I don't share my toys. Okay, so SCM, kind of find it coming down and in. Find your clavicle, and then go posterior on the back. And you're really pushing on something quite hard right in that junction. Lateral, so that junction of the SCM with the clavicle. And you're actually pushing down on the first rib. The first rib's a little different than the rest. The image doesn't show it very well right through here. It looks kind of about the same, but it's really kind of a broad, fat little dude. So that first rib is thin, but it's broad and fat. So it's coming off of that C7T1 junction right through here, and then it tucks right underneath the clavicle to where, I mean, it's almost articulated with that clavicle as it goes underneath. So you can get to it. This CM is going to come right in through here, so you can push on it right behind it. Which, just like we're going to work and do manipulations or assessments of the mobility of our vertebral bodies and the rotational capacity and translation capacity of them, having an assessment of how mobile the ribs are as well. I mean, they can definitely get knocked a little bit out of their most freely moving positions and feel pretty locked up to where they don't want to move. And this is how you're going to get to the first rib to kind of assess that, because it's pretty tight up in this space. So doing a little bit of mobility, you can see how you should have a little bit of give, at least according to Slender. All right, anterior middle posterior scalenes. These guys are coming off the thoracic, the transverse process of the cervical spine. And they're tucking down into the ribs. So there's each of these levels is kind of its own unique little banding. So they're kind of wiry little guys that tuck up in there. They can assist with where your spine is their primary anchor point. They're assisting with elevation of the rib cage. So if we have like forced inspiration, it's helping elevate that rib cage to help give more space. It's also going to laterally lean. So when we're here, it's going to give us the leverage to kind of use the thoracic rib cage, the rib cage as our anchor point from which we tilt the head from one side to the next. Doing releases on these muscles is quite possible. It's about as comfortable as you could ever imagine. Terribly fun and exciting. It'll bring tears to your eyes sometimes just because it's pretty tender. There's a lot of nerves that run in. We're going to go into the brachial plexus, but the nerves exit right in through here as well and come in and down. So, but to find it, SCM is going to come right here. The origination point will be on the thoracic process. The transverse process is right through here, and then it'll drop down. So kind of in that same gap where we push down to find that first rib, that pathway right there is your scalenes. Coming out from your transverse processes down into that same gap that led us to the first rib, that pathway is your scalenes. Any questions on that? Good to go? New releases, you're kind of liking it? Transverse processes. All right. Let's get into the face. Mandible. Easy enough. So we're going to come in, and that's nice little large bone that you can palpate, getting behind the ear and drop in the curvature of the mandible. It's going to give you the start of the jawline as it comes down and around. Your hinge point up here is your temporomandibular joint. And we'll get into mastication and talk quite a bit more about the components of the muscles that create bite and open, protraction, retraction, all that good stuff. We'll do that later. From that position, you can further palpate, so about from that junction to TMJ, if you put your finger, say you find your ear and just go slightly anterior to it, you can feel that jaw open and close. But it's kind of pivoting right underneath around this, which is the zygomatic arch. So you have this archway that comes forward as well. So we'll do Dolan's lines in just a minute to kind of reinforce a palpation of the frontal assessment of where these bones are. Now, in there though, so if you find, again, the arm of going down to the body of the mandible, you find the zygomatic arch, and then kind of in that open field space right behind it, that's your masseter. So that muscle actually tucks up underneath that zygomatic arch and gives you that closing bite, that elevation. So it's a nice big massive wad of muscle. But temporalis, off to the sides, we're coming through here, we've got your temporalis muscle, which fills in the temporal bone area, kind of that big area, dropping down underneath, which again helps the elevation of chewing. So if you put your fingers above your ear and kind of leave them resting there, and then bite, close and bite, you're going to feel that muscle contracting as it assists with elevation of the jaw, of the mandible. Good place for head massages, feels pretty good. You can nice and calming and relaxing. Zygomatic arch.
Why is it showing us pictures like supine and seated? Like, why does it have pictures?
How would you do that? Would you like them prone?
No.
That would make it difficult
I'm
because
just
of
curious,
facing.
like, if it's like different besides like the view.
More so just to kind of make sure they have the person's life still in the picture. If you're going to do manual therapy work on those people, if I'm going to do a lot of head, neck, face, then having them supine is kind of an easy way to get at most structures there. So I think it's more indicative of that. So you can let me know if this one's up there too.
Balance.
The head. So there's a whole lot of little bones floating through here, but not everything is palpable. Again, mandible and your zygomatic arch, which is junction with your temporalis bone, your temporal bone. And then we start getting into the maxilla, so we'll go through Dolan's lines to kind of fill in the rest of those. Why do we care at this point? Well, obviously, if we have a significant injury to any of these structures, then that's going to be a pretty quick immediate referral to kick somebody out the door and get the help that they need. But knowing who they need to talk to, but more importantly, knowing enough about these areas that you can identify when we have a significant problem. The teeth that bite, you start seeing any teeth that are out of line with the others. That's a unique facet, unique to them. They used to have straight teeth, and once now they're pushed up or pulled down. These are dental emergencies. Just send them, especially if it's off hours, that's where you would send them more or less to the hospital, the emergency room. Because even if your ER doc isn't someone who can manage significant oral issues, they will have somebody on call who can. So leave it up to them to kind of coordinate that care to where you're not sitting here trying to call a dentist off his hours, unless he's like your BMF. It owes you a lot. Otherwise, just use the on-call system that exists at the hospital. All right. Principal bones that we have. Again, we've talked about zygoma right up through here. The mandible and the maxilla make up the majority of the front exposure of the facial bones. Beyond that, above it, the bridge, we have the nasal bone right here. There's two of them on either side. The frontal bone clearly with the front part of the head, and that's a lot of what's exposed. Deep to that, we have the bones that make up the eye socket that are inside. This maxilla largely makes up the floor of it, even though it's very, very thin. If we're going to end up having a blowout fracture, so somebody takes a ball to the eye, that pressure hitting here it's called a blowout because that pressure as it hits the front of the orbit explodes it backwards, and typically that floor is the weak part that gives out. And so you'll see that eye kind of sink down because the floor is now shattered. But lacrimal bone is this little guy right in here. Again, it's inside the eye socket, just on the inside of, right next to the lateral sides of the nasal passages. And then the vomer sits right in here. And then we have the sphenoid, the ethmoid sitting deep in behind. Palpation-wise, there's 3 easy lines that we can kind of follow that are going to hit all of the frontal facial bones, which is why I tend to use this as a tool for both assessment, but just remembering which bones. And then it clearly hits everything as you move around through it. My expectation for the purpose of the exam when you're looking at something like this is just know that pathway for each of the lines. Know what bones you're palpating as you move from one to the next. So line 1. So you're going to start up here on the frontal bone as you go into the nasal bone. And you're basically going to palpate your way around the eye orbit, which gets into your maxilla. And that comes back up into your frontal bone as it comes back up. So frontal, into nasal, into maxilla, which comes back into, well, the zygoma into frontal. So frontal, nasal, maxilla, zygoma, frontal. And so from that point, when you come back up here, if you kind of roll your finger posteriorly over that ridge that is the lateral aspect of your eye socket, that's going to get you right back up in here. So you've got frontal bone still, down into zygoma, and then you can follow your way down the zygomatic arch on the superior side. And that's second line. So that one's nice and easy, because it just goes frontal to zygoma. And then line 3, so where that zygomatic arch is right here, just drop over it to go inferior, and then you're going to follow it, the inferior aspect of the arch, forward into the maxilla. And then you can do a palpation on the mandible entirely separate. But that hits every bit of your facial bones. So frontal, every bit of the outwardly exposed from the facial bones. You get the stuff that's deep. It can be a little bit more problematic. Obviously, we're not going to do palpations. Stick your finger up your nose, see if I can't reach that effluent. Probably not so much. So frontal, nasal, maxilla, zygoma, back to frontal. Then flip over that ridge, and then come from frontal, and then follow the superior aspect of the zygomatic arch. Go over it to the bottom, inferior side of zygomatic arch into the maxilla. You got the face covered. So if there's something broken, you probably would have hit it there. At least if it's a facial impact. Nose is kind of tricky. There's not a whole lot that... It's like somebody ran some string up the foregrass nose. It's really kind of a random thing to add to a drawing. But whatever. So from this point where the nasal bone meets, the rest of this is all cartilage. That's why your skulls look like they're all Voldemort, missing noses. When you get hit in the nose and it really hurts, like right up here on the high part of that bridge, you're actually stressing that joint between the cartilage and the nasal bone. So that kind of blinding pain that sits right up in here between the eyes, that's really where that joint is that comes in between them. Like most other facial structure features, more often than not, if I've got significant trauma, or I suspect there's enough reason to believe there was significant trauma, these guys are referred to an ENT just to make sure. I had a baseball player who was our shortstop, but he was a big dude, like crazy quick for a big guy, but he was a big guy. Weighed something like 260, and it was when we were up in Boston, and there's snow on the field until about, I don't know, June. And so we do a lot of our practices in the gym. And so they were hitting balls, and he was trying to field balls on a basketball court. And he decided one day to lay out to catch it, and he did full extension, and he caught his body weight with his nose. Like he laid out so far that his nose was the first thing that came in contact with the ground. It didn't look awful. Like it wasn't like his nose was crazy sideways, but also it didn't seem like that was going to be a minor impact to have 260 pounds landing on that nose. And so I sent him in, and he'd actually collapsed the sinus cavity underneath that had that reconstructed. So again, just be mindful that if you suspect there's something not quite right, elicit help above and beyond yourself. So you inhale through the nose, and that's going to mix the air through those concha, those inferior middle, all that kind of stuff you got with anatomy. A&P class a long time ago. And by mixing this with the moisture, by the time it actually goes down into your airway, into your trachea, it's heated up to your body temperature. So breathing in through your nose gives it more time to circulate and warm up. If you breathe through your mouth, then, especially in cold weather, you're taking that shot straight into your trach, which can be a little shocking to your system. Makes it a little bit hard to breathe. But through your nose, increases that temperature and helps your body regulate it a little bit easier. Any idea how we smell? believe it or not, it's actually the vibration of the molecules. So every molecule has a unique form, like unique structure, and it's the vibration of those atoms on that molecule that make a unique, yeah, crazy. Bless you. And so they were actually able to take it. There was a study that was done that they chemically altered one thing to change or mimic the vibration of another, even though it was nowhere near the same molecule shape, but it had the same vibration. And then sure enough, they gave it to somebody. They couldn't distinguish the smell of almonds to whatever this was. It was crazy. So much fun. There's your eye socket. Again, so we've got so sphenoids tucking back in here with your ethmoid, give it a little bit. The palatine bone kind of slides in, hiding back up in there as well. So there's a lot of form and structure to the eye, but it's usually this maxilla piece right here. You can see how that kind of makes up the floor. And then this is your zygoma coming out wide. So this is your nose on this side, maxilla, the zygoma. So if you've got a ball that hits, that force that would blow it out tends to take out that weaker flooring of the maxilla. The lovely eye, I would be able to identify just the components so you know what you're dealing with. So coming on the outside, that outer limb is, that outer covering is your cornea, which begins bringing the light in. The pupil itself is the hole that's largely controlled by the iris above and below, which is the musculature that kind of opens and constricts. So the pupil is controlled by the constriction of that iris. Then the lens, it hits that lens which refracts the light and changes its shape, flips it upside down, inverts it, hits it on the back. So when you've got looking at myopia, so nearsightedness and farsightedness, then it has to do with the size of the eye such that this lens is either aiming it too far back or too far forward. And so lens eyeglasses tend to help correct where it hits the back of the wall and the optic nerve, and the retina can track that back into the brain the way it needs to. So main pieces we're concerned about. I mean, if you get a scratch on the eye, it feels like there's something forever in there until it kind of heals. There's medication you can go in and slide in, not medication, but I think it was called blue with some. There's a stain that you can use to touch on the white part of the eye and have them blinking around, and wherever there's a scratch, it'll stick to more, and so you'll identify that, yeah, there's a scratch on there. So it's a pretty easy way to identify if there's an issue. Redness in and around the white is common. If you start having like all the pussy grossness, you start looking at conjunctiva, pink eye, all that kind of fun stuff. Where we get really concerned is when we have trauma in here that leads to bleeding. So certainly if we have a globe rupture, that's kind of a big deal, send them on. But if there's bleeding in here, then that bleeding can come up and start pooling in the front of the eye, or what it's called. So yeah. Gotta look that one up, Brett.
Huh?
You gotta come back and look that one up. Yeah. When we start having pooling in the blood with this coming up in here, our biggest concern is actually that there's structural damage to the eye. So we need to get that assessed. But with that pooling, that red can actually stain the cornea up in here, or stain the lens on the front side where it's exposed to, which is going to leave a permanent discoloration in that individual's eye. So when you have that, then you, if you start seeing blood pooling up in this area, towards filling up the inside, then you need to have them lay back so it drains backwards in here. More often than not, it resolves itself within a few days, but it's still something you need to have referred out to get addressed. Now we can also have some really cool there's something called a teardrop pupil, which is unfortunate. And it is indicative of trauma. It's indicative of trauma to the globe itself, to wherever the damage is. The teardrop distorts the tension that can be produced by the iris, and so it points in the direction of that damage. But at the same time, there's a condition to where people's irises don't fully form called coloboma, and that's what this is all imaging of. So the iris itself didn't fully form, so this child doesn't have any particular damage. It's just kind of how their body finished putting them together. And it can be anywhere from just something unique to look at on somebody to it having significant impairments on the body, because this is on the visual field. Because obviously that helps control the amount of light that comes in, and so if you lose that control, then it can impact some of your vision beyond that. So the term is hyphema. There's an A at the end.
I was thinking about something else.
It sounds like you're trying to say anisocoria, which
Yes.
is completely different. All right, so again, we start getting pooling of blood in that anterior chamber of the eye, and that would be indicative of bad signs. So that would probably be somebody I would like to get to the hospital to get that eye, to make sure we don't have structural damage. If you take an impact to the eye, then we can definitely have internal bleeding, and that could be here, which means it would resolve hopefully on its own, but certainly we want to get involved with the right folks. And recognize, like in images like this, that the whites are all still very clear, but there's blood beginning to pool in and around that iris over in that anterior chamber. Musculature for the eye, so lateral rectus, medial rectus, superior and inferior, and then when the inferior has an oblique as well. So we're going to be able to grab that eye from either side and turn it, or we can rotate it to some extent with that inferior oblique as well. And then ear, conductivity. Sound waves come in across the pinna, which helps channel it into that ear canal. It's going to hit that ear drum, which will vibrate that tissue, hitting the three tiny itty bitty small bones in the ear, the anal stapes and the hammer. And from that, it recreates the pressure waves that go in through the spiral organ. And the spiral organ is a bunch of hairs inside, depending upon the length of the tone, the vibration length of that sound wave changes how far through it gets, which means it changes how far in of a hair that it can hit. Each hair is going to be triggering different levels, different sounds, pitches, tones. So as we start getting conductive, we'll start getting hearing loss in through here. We start losing some of those, damaging some of those hairs that pick up those first tones. There's all kinds of like middle school ringtones that are supposed to be at pitches that adults can't hear. Have you played with those before? Now, eustachian tube, which comes in and connects with the sinus cavity, and so if we start getting infections or otherwise, it can start clogging that up, which causes pressure issues on that inner ear. So you'll hear about people getting tubes, and that's helping reinforce this eustachian tube to where it can continually drain and make sure that stays open. Likewise, we have these, well, not likewise, we also have these semicircular canals up and through here, and these are kind of like an X, Y, and Z axis. And it's your vestibular system, so it's controlling your sense of balance, your sense of what's level versus what's not. Which sometimes when we get inner ear infections that cause pressure problems, it's distorting some of that balance problem, the balance management, and so it makes you want to fall over when you try to stand up. Simple enough? From way back in the day? Cool. Now the fun stuff. Cranial nerves. All right, you ready? So I'm going to give you a phrase. I'm going to give you an acronym. On, they traveled and found Voldemort guarding very ancient Horcruxes. Got it?
No.
On, they traveled and found Voldemort guarding very ancient Horcruxes. Got it?
I don't
You
know.
want it again?
One more time.
On, they traveled and found Voldemort guarding very ancient Horcruxes.
I don't know how to spell it. What? I just don't know how to
Just spell the last
I
one.
just don't know how to spell it.
Court.
How's that?
You're saying court. Court.
Horcruxes.
Oops.
Okay.
What's a freaking H? Now, you may, if you so desire, move away from the world of Harry Potter. If you type in cranial nerve acronyms, there are other options out there. However, the one that I was taught in my undergrad is not the most appropriate thing to start spitting out in class. So I'm going to stick with Harry Potter. It keeps it clean. In our country, it's safer to talk about witchcraft than it is sex. So we'll leave it at that. Excellent. So, off to the side of that, basically the first letter of each of those is going to be the name of a cranial nerve. There are 12 cranial nerves. So let me go ahead and let you get those, and we'll go through what each of them are as we go. So, olfactory, optic, oculomotor, trochlear, trigeminal, they travel, and abducens, found, facial, very, so vestibular cochlear, which is also called acoustic sometimes. Voldemort, guarding, glossopharyngeal, very, vagus, accessory, ancient, hypoglossal, Horcruxes. So they're numbered based upon where they exit the brain. So there is a rhyme and reason to it. So if you look at the base of the brain and look upwards, Then olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, Voldemort, vestibular, cochlear, glossopharyngeal, guarding, very ancient Horcruxes, vagus accessory hypoglossal. So there's a rhyme and a reason. It's kind of an anterior to posterior, top to bottom kind of thing. So, olfactory. It's a sensory-based nerve. Okay, so location of cell bodies, don't worry about. Cranial exit, don't worry about so much. Main actions, I want you to know the names of them and what they principally do, and more importantly, how we assess them, how we test them. Even though it's not necessarily an assessment class, it'll help you because you will be given that information later, and it's just something you need to know. So main action is smell. Comes out of that cribriform plate, a whole bunch of like little hairs sticking out. So, olfactory bulb, the tract, and then there's your nerve that kind of sticks out and fills in the space to pick up whatever sense. And seeing as how this passage through your mouth is so intimately tied, your sense of taste and smell are very, very close together. Get a cold where you get really stuffed up and you can't smell much, and all of a sudden everything tastes bland. Bummer of life. Cranial nerve 2, optic. This is vision. So again, a sensory, somatosensory is the SS, so it's a sensory, and it's given vision from the retina. Three, 4, and 6 are going to control eye motions. So oculomotor is going to be first. So SM is somatomotor. So it's going to move the eye, so it's not a sense so much as it is an action. So it turns the eyeball up, down, and in. So superior, inferior, and medial. Trochlear is the next one. Turns the eye in for a lateral, which is going to be down and out. So oculomotor, up, down, and medial. And then trochlear is going to go down and out. Posterolateral, down and lateral, inferior lateral. Still answer one of this for. And I'm going to skip number 5. So we're going to do abducent. So abducent laterally moves the eyeball out. So if I'm going to do an assessment so far, olfactory, take something that smells. Take ammonia. Take a smelly marker. Have them close their eyes. Can you smell this? What do you smell? Optic. Visual acuity, clarity. Cover one eye, read something across the room. Easy enough. Your Snellen eye charts that you've seen in all over the place in your life. 3, 4, and 6 are movement patterns. So if you just have somebody, I say, follow my fingers, and you go up, down, in, out, and out. Up, down, in, out, and out. Right? It's kind of an H pattern, up, down, in, and out. So cool random story, because I love this story. It's one of my favorite of all times ever. So I worked with a women's football team in Chattanooga. And like the coolest team ever, coolest people, loved working with them. It's one of our last games, and 3 plays before the end of the game, one of our women gets hit hard. Her name was Soccer. We called her Soccer because she was our kicker at the same time, also a kicker. but just intense, very good athlete, very strong. She gets hit, gets knocked down, gets back up, slides back into play, finishes the game, and we're all kind of walking out, and then within a few minutes, like her teammates get her up in the locker room, and they come back out, and they're like, Reed, you've got to come. You've got to go check out soccer. Have her come out here. She's in the women's restroom, like the women's locker room. And no, it's clear, you've got to go see her. So she's in there, and she's just sitting on one of the benches with her head back up against the wall. Doesn't look like she's in any significant distress. She's kind of chilling like that, eyes closed, leaning back. Soccer, what's going on? Nothing, I'm fine. I was like, cool, so to convince me of that, you get to open your eyes, look me in the eye, and tell me that. She's like, I'm fine, go away. All good conversations start with telling me to go away. So, what's wrong? Open your eyes and tell me what's wrong. She's like, I can't. What do you mean you can't open your eyes? I can't open my eyes. Okay, so in this, we have a problem that negates the whole I'm fine thing. And she's like, hold on. And so she does. She like fights it, and she finally opens her eyes, and they're in and up. Like her pupils, her eyes are in and stuck here. She's like, and it's like obviously clearly bothering her. So she closes it back up. It's like, so what happened? Like, I got hit in the head, and I can't open my eyes. So she played the last 3 plays of the game where she couldn't open her eyes and see. There's a logic in this somewhere, I'm sure. It's like, okay, so soccer, here's the deal. This is called cranial nerve damage, and you're going to the hospital now. She's like, F you, no I'm not. Right? So I mean, she's 20-something years old, so it's not like I could force her. It's like, okay, well, we're going to call the ambulance, and you get to tell them that and refuse to go. She's like, hold on. Give me 10 minutes and I'll fix it. I love people. So if there's any moment in my life that I could go back to, if I could possibly have video recorded this with her permission or whatever, but if I could have, it'd have been so cool because she seriously sat there, after an EMS was called and all that jazz. We still gotta wait for him, right? So she seriously sat there and she'd sit up, she'd open her eyes, and she would like fight to create focus, and you'd see like one pull down and the other one's still up there, and then she'd get frustrated and then go back and she'd lean back again. And she kept doing it. Sure enough, in 10 minutes she could hold focus again. Like, wow, that was crazy. Just to have like the film of her trying. Oh, that would be so cool. So what nerve do you think that was? 3, 4, 5. See, which ones do what? So oculomotor goes which direction for the eye? Up, down, and medial. So if it wasn't firing, then, well, if we lost up and down, it probably would have gone lateral. Because medial wasn't firing to pull it in. So not that one. 4. Infralateral, down and out. So my guess is there because they were up and in. So there wasn't a balance to pull it, to hold it. So that's my guess. She never ended up going to the hospital. She had a bad enough concussion she doesn't remember any of this. Oh, dude, so cool. All right. That's going to go back. 5. 5 is called trigeminal. Tri means there's 3 branches: ophthalmic, maxillary, and mandibular. And the names very conveniently kind of go over the regions that they do. So mandibular is going to go over the mandible. Maxillary goes over the maxilla. And ophthalmic goes up and over the eye through the eye socket and down around the nose and the frontal bone. This is a sensory-based nerve. So it's the touch and feel through these regions. So you can take a cotton swab and just brush it over the cheek, so over the top, across the zygomatic arch, and then down over the jaw. And you're asking if they can feel both, as compared bilateral, the same. Maxillary and mandibular. Now, mandibular also does the anterior 2/3 of the tongue for sensation. All right, facial. Predominantly a motor nerve in one part, and then the other part is sensory. The facial is doing a whole lot. But this is the musculature of facial expression. So smile, frown. Stapedius of middle ear, stylohyoid, and posterior belly of digastric, which are swallowing functions and speaking. But it's in the sensory aspect that it matters. So anterior 2/3 of the tongue is taste. So if I go and take something like a piece of lemon and touch it on the front of your tongue and say, do you taste that? Then we're assessing facial nerve. So a whole lot. Smile, frown, anterior portion of taste, and we're pretty good to go. Number 8, vestibulocochlear. We're going to split that into two different nerves. The vestibular branch and the cochlear branch. Cochlear is just straight hearing. So get behind them and then you can move a snap from left ear to right ear, much like they do for hearing tests, to where they change the location of pitch. Can you hear me? Raise your hand on the right for whichever side you can hear somebody. So you hear it on this side, raise that hand. You hear it on that side, raise it on that hand. The vestibular is equilibrium, which is, again, the semicircle canals, the semicircle archways, the XYZ axis of balance that I was talking about. So you can have the individual do balance testing. Stand on one foot. Let's see how they do. In what ways does your body manage balance? You want a fun test? Stand up. Really? He just does this to make us fall. Yep, I do. Okay, so first things first, hands out wide. Pick one knee up to 90. I'm not sure I should do this with swimmers. It's dry ground. Okay? Nice and easy, right? So what all is our body using right now? Huh? It's using muscles. Yay. So we're taking information from the world around us and letting it, and it's coordinating us not falling over. It's easier if you come out wide because I can control that. If I come in really close, then I don't have quite that leverage, that balance to offset. Okay, so you come in here, we take out some of that external use. That knee's up to 90. And the next thing, I want you to tilt your head back all the way and look at the ceiling. Feels a little different because our body actually uses the visual horizontal. So if we take away that horizontal and then we go tilt those semicircles off a little bit, then we lose some of that. Now the last piece is we're still staring and using some of that horizontal by seeing the lines in the ceiling or seeing the visual component of that. So if we want to just use the interaction of the mechanoreceptors in our joints up to our brain to then control the muscles easily, then in that position, then close your eyes. And she failed the drunk test. So if you're here, head back, and then eyes closed. And all of a sudden, all of that stress, all of that requirement is now based on the feel of the joint sending information up to say if you're falling. So if you get somebody who's sprained an ankle, this is kind of that progression to where we want to remove everything except for that communication pathway from the mechanoreceptors in the joint and the relay with the muscles. So take out the vestibulocochlear's influence along with the optic nerve influence and just focus on the neuromuscular control, the mechanoreceptor control. So there's your vestibular. All right. Number 9. Glossopharyngeal. Assistant swallowing. Motor function. Assist with salivation. We hit a couple glands that help salivation as well. Taste on the posterior third of the tongue. A little trickier to kind of make that delineation between the anterior 2/3 and the posterior third without kind of choking them sometimes. The easier one to focus on individualized testing is that it gives you skin, like cutaneous perception around the ear. Oh, dude, class is over. It's 1:15. 1:16 actually. So we'll finish later. It's all good.
Okay.
It's okay to tell me this thing.